All right, hi everyone. Great to be here. Exciting times in medical care with AI basically everywhere around us. A couple things a little bit about stroke, so in case you folks don't know, if you're not in the medical field. Stroke kills about 140,000 Americans every year. It is the #1 cause of long-term disability in the United States, resulting in about a $75 billion cost to the system, to the healthcare system annually. Strokes are divided into two different kinds. One is the clot, called ischemic stroke, and the other type is called hemorrhagic, where there's a burst blood vessel in the brain. And the most important part of this discussion is the fact that if you know you have a stroke early and your clinicians have imaged you appropriately, you likely will have a very good outcome and survive unaffected. But it's all about time is brain in stroke. So we're going to talk about the Rapid platform for imaging stroke. Rapid has been FDA cleared for about 5 years. We are in about 1,400 hospitals worldwide, and we see about 450,000 stroke images per year. We have a group of different kinds of AI functionality. One is CTA, one is CT perfusion, and we also have automated aspects and automated hemorrhage detection, not yet available in the United States. And we'll talk a little bit more in detail about those in a moment. The function of Rapid is really the AI that's in the server that's analyzing the results. But additionally, Rapid then presents the results to the user in PACS, in email, and on a Rapid mobile app. So it all depends on the type of workflow you want to have within your facility as to how you leverage our results. So Rapid is a platform, and we continue to add new functionality as new AI modules are built. It's completely scanner agnostic, so it works on GE, Siemens, Philips, Toshiba. And as I mentioned, we're in countries around the world with all different kinds of scanners with all different kinds of capability. This is a little bit about our global reach. We're in about 45 countries, about, as I mentioned, 1,400 hospitals, and about 450,000 cases come to us annually. A very important part of what we did, and you should ask all the AI vendors here about this, is whether they've been validated in clinical trials. Rapid has been in many clinical trials, and in fact, 5 of them were published in the New England Journal of Medicine in the last 5 years. So a big part of what we believe in is the science of analytics of the brain, and then prove it by being in clinical trials, saying that your results mean something clinically as well. We're actually now in 2 additional clinical trials, one funded by Roche, which is Genentech, looking at treating strokes out to 24 hours with medications as well. Right now it's only treatable by surgery out to 24 hours. And we're also using, in another trial with a company called Biogen, which is using Rapid to analyze whether medications can help reduce the swelling of the brain after a significant stroke. So our friends at AWS asked us to talk a little bit about exactly how we work in terms of our functionality. Rapid is able to install many different ways. We install on a virtual machine within a hospital, or we can also use cloud services to connect multiple hospitals to a virtual machine. So you can see that here. You also have the choice of having Rapid in the cloud for cloud processing. So using a strong partner like AWS has made our life a lot easier because of their tight security requirements, which all hospitals have. They're very sensitive about patient information leaving their facility. And if you can show those hospitals that that PHI, the patient protected health information, is leaving in a secured environment, they're very comfortable using advanced resources. A little bit more about our comprehensive stroke solution. What ends up happening in the United States is only about 1,000 hospitals are truly comprehensive enough to handle the most advanced kind of stroke. Yet there are 4,000 other hospitals out there that see those patients as well. So a big part of what we're doing is we're installing what are called hub and spoke networks. The main hospital, the big hospital that has full capabilities, is installing to their peripheral hospital so they can analyze a patient as well, and then get the right patient transferred within a short amount of time to the right surgery center for the surgical procedure or medications. An important part of this is that imaging that's done, because with that imaging, you can decide if that patient is treatable, may not have a stroke, or is not treatable, and why bother to transfer in those two other scenarios. Going back a little bit, and it could be a progression of capabilities. Some hospitals only have the capability to do a non-contrast CT with no intravenous injection. Some can do a little bit more advanced imaging with what's called a CTA, which analyzes a sort of a single snapshot of the brain. And the other one actually analyzes the brain for about 60 seconds to see how that blood flow is going through the brain, and can tell the doctor not only is there a clot, but how significant or how much brain is dead already when the patient showed up, and how much brain will die if you don't remove that clot from that patient's brain. This is a new piece of functionality that's not yet approved in the United States, where it can differentiate, Rapid will differentiate from a very simple non-contrast CT whether there's a hemorrhage or not in that patient's brain. Because with hemorrhage, there's a whole different type of treatment cascade that you have to use. You can't give a clot-busting medication because they will actually bleed more. So it's an important piece of this puzzle of analyzing stroke. Rapid Aspects is available in about 45 countries, not yet available in the United States. And what this does is analyzes using a non-contrast CT how much brain is dead at arrival, so that you can decide whether this patient should be moved on to additional therapy or the stroke is complete. And then I mentioned before Rapid CTA, which is a very nice piece of functionality. Rapid, in about 2 minutes, will analyze that scan, tell the doctor where the clot is, tell the doctor how significant the clot is, and as well produce additional rotational images so you can see the actual source data, as well as a 3D rotation of that brain. So we use color-coded maps to basically tell the doctor where that lesion is and how significant it is. And then I mentioned CT perfusion before, which is our flagship product. It's the one that was published 5 times in the New England Journal of Medicine. And basically what this does is says, again, when that patient presented, based on the analytics of blood flow through the brain, how much brain is already dead at presentation, and how much brain is going to die should that clot not be removed or dissolved. We're also the only company in the world who got the FDA clearance to actually say in the results whether that patient is qualified for the surgical procedure called thrombectomy. And that was because of all the evidence we had about Rapid in these published academic journals. So when we first started as Rapid, we had the results available in your PACS system. We had available in a de-identified email. But in this day and age of everybody wanting a mobile device, we now have established the ability to have the results on a mobile phone. So it's compatible with any mobile phone. And basically that result that went to the cloud or went to the Amazon workstation, Amazon cloud, or to the hospital's intranet, will then send a subset of that result either with or without patient information to a mobile app. And that mobile app gives the docs the ability, especially because these docs are often not in the hospital when the strokes happen, right, 24/7, 7 days a week. It could happen that that doc is here and they are able to analyze that case and call their staff and say what to do next, or they can even message through the app to their team to say what to do next. So it's very good for collaboration as well. Because strokes happen basically anywhere, we now have enabled Rapid on mobile stroke units. So there's a couple of companies now that have their scanners literally installed on ambulances. So if you get an ambulance call, that mobile stroke unit is dispatched. If it sounds like a stroke patient, they scan the patient on site near the patient's house or at RSNA. And that result, again, that data result goes and gets processed, and you can have all that information available from a mobile stroke unit before the patient hits the hospital. Does 3 things. Number 1, could tell you that it's not a stroke. You don't need to go to a stroke center. You can go to your local hospital. Tells you that it's a stroke that's small or stable. You can actually start administering the medications to help treat that stroke before the patient even gets through the traffic of Chicago to the hospital for treatment. It also will help them decide what kind of hospital you need to go to. Can you go to your local hospital, or do you need to go to the thrombectomy or surgical center for treatment? And these are some of the sites that have the Rapid system on their mobile stroke units in ambulances. So so the mobile stroke unit is really in the field level imaging. The most common imaging that's done is in the radiology department. And now what we've done is we've enabled rapid to be available in the operating room itself. So that if you have a patient that you're pretty suspicious that that stroke needs to be treated, but you're not 100%, on the operating table itself, you can give the patient an injection, run the data through Rapid using a C-arm or a biplane unit, such as the Siemens unit you see here, and have that result available to you in about a minute to be able to decide whether you're going to do that case or not. So in summary, what we've done here with artificial intelligence and cloud services and on-prem installations is we've dramatically impacted stroke care. We now, as I mentioned, are doing about 450,000 cases a year in about 45 countries in about 1,400 hospitals. And again, our services are such that we have the ability to install however the hospital wants to see those cases, their software installed, whether cloud, whether a local network, or actual local installation. And then we also have various functionality depending on their specific needs. I now actually want to take you into some real cases. As I mentioned, we have probably about 40 hospitals in Chicago. We have a great partner with us in Wisconsin. In fact, the doc's here in the audience. And he has allowed us to share his patient cases, and he's gotten permission from every one of these patients to share their cases publicly. So this brings it home. This is a 46-year-old female, found down at home more than 72 hours out. Until the beginning of 2018, stroke was basically not treated after 6 hours. Now with all this new data being published in the New England Journal of Medicine using Rapid, we've been able to establish that you actually can treat patients to an extended time window. So this patient previously with an NIH score of 27, which is basically near death or wishing they were dead, not able to move half their body, not able to talk, maybe not able to see, had a significant stroke. A little tiny dot there indicates the stroke is there, the clot is there. There's some tissue changes that are very subtle that you may or may not be able to see. But then using AI and Rapid is able to quickly call out the location of the lesion. And in fact, this patient had 2 different clots within the same blood vessel, so it's called a tandem lesion. This was the CT perfusion image. So this patient showed up very late in the game. Normally would have been written off and said, you can't treat this patient. But in this case, Dr. Gibson saw that this woman had about 30 cc's, about the end of my thumb, of her brain is already dead. But she has something about 4 times that size that's about to be the final amount of dead brain. And if she were in this final state, she would be either dead or permanently in a nursing home at the age of 46. But given the fact that he had this information, was able to transfer the patient to the right center for treatment immediately, he was able to do this in the operating room and see the blocked blood vessel, pull out those 2 little pencil eraser size pieces of clot, and regain the circulation you see here. And the most important part of this is not what you did surgically, but what was the final outcome. So this patient, who would have been permanently devastated in a nursing home for the rest of her life, now basically went home at the post-op day 7 with a mild deficit, and the stroke scale, which was originally 27, she went home with a stroke scale of 5. Likely she's going to recover to basically normal within 3 months. So again, a massive impact on patient care. Another interesting case. So that case I presented earlier was a patient who had an extremely big stroke and an extremely extended time window. This patient also is almost 80 and came in at about 33 hours, a very mild stroke. Stroke scale of 3. Most people would have said, don't do anything about this patient, too much outside the window, very mild stroke, just see what happens. But by analyzing the Rapid results, you can see that there was an obvious occlusion. Once again, Dr. Gibson could see that there was no dead brain yet, still hadn't died. But what will die, 32 cc's of brain, about, again, the size of the end of my thumb. So, and he had he doesn't need it, but if you're in a smaller hospital that doesn't have full capabilities, you have this nice little indicator saying this patient may need a thrombectomy, the surgical procedure. So again, he was able to see in the angio suite, see where the occlusion is, find the clot itself, And again, these look very dramatic, but they're literally the size, they're smaller than the end of a pencil eraser. And regained the circulation. And basically this patient went home perfectly normal post-op day 3. So instead of potentially a life of not being, further life of not being able to speak, because that was his problem, aphasia, not able to speak, he's going home normal to his family, hopefully paying his medical bills, paying his taxes, being productive. So in summary, what we've done with Rapid is over the course of 5 years, getting it into thousands of hospitals, impacting hundreds of thousands of patients, impacting stroke care around the world, and basically bringing people back to life when they were feeling like they should be dead or very physically devastated.